So, good morning, everybody. Welcome back to the Tuesday morning academic session from the Higgs group. We are happy to have all of you joining us this morning. Last week, we had an excellent description of how you can use echocardiography to give a lot of information in the intensive care unit by Dr. Gurprasad. And we take it forward from there and look at an important aspect of hemodynamic assessment and hemodynamic optimization, which actually helps us a lot in salvaging a lot of difficult situations, and that's knowing about the right heart. Intensivists especially need to know a little bit more about the right heart than the others, for the simple reason that a lot of interventions we do are linked or have consequences for the right heart. So the reason why I'm saying this is the right ventricle is the gateway to the circulation. If you look at how hemodynamics are managed or hemodynamics are assessed, you try to look at giving fluid to the patient, which is something which you are trying to load the right side of the heart. And you will then look at the consequences of this loading of the right side of the heart by measuring something that is happening at the left side of the heart, whether it is mean arterial pressure, whether it is stroke volume, or whether it is cardiac output, or ultimately the systolic blood pressure. So, understanding the right ventricle is something which is very key to understanding the entire gamut of metabolic optimization or homeostasis in a critically ill patient. Embryologically also, the right ventricle is distinct from the left ventricles, and anatomically, there are a lot of differences between the right ventricle and the left ventricle. The amount of muscle mass which the right ventricle has is a fraction of what the left ventricle has, and the amount of diastolic blood flow that goes into the right side of the heart is also a fraction of what goes to the left side of the heart. Consequently, the ability of the right heart to sustain strains and oxygen demand supply imbalances is much less when compared to the much well endowed left ventricle. As I've said before, interventions for hemodynamic optimization start at the right ventricle. Previously, we used to measure CVP to ensure that the patient's volume status is good as a measure of hemodynamic optimization, and that is a true measure of right ventricular preload. Intervention at the right ventricle is the one that is most commonly done. Now, suppose you are dragging out fluid for a patient who is hypoxemic, you are trying to offload the right ventricle, hoping that the perfusion pressures, which are a marker of the left-sided heart function, are improving. So you are intervening for hemodynamics on the right side of the heart while you are monitoring the left side of the heart. So what happens at the right side is critically important because the right ventricle and the left ventricle are interdependent upon each other. But when you look at routine assessment and you look at most of the training programs on echocardiography and hemodynamics, not much attention is paid to the right ventricle. It is a forgotten ventricle, but it's the vein with an attitude is what you can describe as right ventricle. As several experienced speakers and experts in the field of hemodynamics have commented, the right ventricle is behind every successful left ventricle, or you can say behind every successful left ventricle, there is a right ventricle. And to explain that, you need to look at the anatomy. In anatomical situation, when the pathophysiological processes are not active and the heart is healthy, the right ventricle is actually behind the left ventricle. As you can see in this picture, this is the LV, and behind that you find the right ventricle with the tricuspid and the pulmonary valves on either side. But when this right ventricle undergoes volume or pressure overload or strain, it tends to creep outwards and comes to the other side, to the side of the left ventricle. That's when it starts impeding the functioning of the left ventricle. As long as the right ventricle stays behind the left ventricle, the left ventricle is very efficient. But once it starts creeping outwards and surrounds the left ventricle, that's when the hemodynamic efficiency of the left ventricle begins to drop. Let's look at a few facts about the right ventricle. It has two parts, the body and the outflow tract. and it has superficial fibers which are continuous with the left ventricle, and there are fibers which are deep within the interventricular septum. Unlike a syncytial movement that happens, or a very smooth C wave like movement that happens, the transmission of impulses in the left side of the heart, in the right side, it is a peristalsis, much like intestinal contraction that happens in the right side of the heart. So there are subtle differences in the way even the physiology, the electrophysiology of the right ventricle behaves as well. Anatomically, the free wall of the right ventricle, as I said before, is a fraction of the free wall of the left ventricle. That is, it is 4 millimeters thick compared to the 14 to 18 millimeter thickness of the left ventricle. The requirement for oxygen of the right ventricle is also 20% of what the left ventricle requires. Therefore, the coronary circulation is also equally minimal when compared to the left ventricle. However, the amount of work which the right ventricle does in pumping the amount of blood is exactly the same as how the left ventricle does, because the entire circulating blood volume returns back to the right heart and has to be pumped forward. So the amount of the blood that is pumped out of the RV is the same as the amount of blood that is pumped out of the LV. The pulmonary vascular resistance is probably 10% of the systemic vascular resistance. So the pulmonary circulation and the right heart are not used to higher resistances. So they cannot work under too much of stress. The right ventricle also has a peculiar characteristic of deriving its blood flow through both systole and diastole, and therefore, when there is pulmonary hypertension, the right ventricular systolic pressure always has a bearing on how much perfusion it gets. If the right ventricular systolic pressure is more than the mean arterial pressure, the perfusion of the right ventricle falls and you have right ventricular ischemia. Electrophysiologically, there are three phases of contraction for the right ventricle. The phase 1, which is the contraction of the spiral muscles, and the phase 2 is the movement of the free wall towards the interventricular septum. The third one is the ringer effect, which happens because of left ventricular contraction. Suffice to say that the left ventricular contraction is also a player in right ventricular contraction. The weak muscle mass of the right ventricle makes it more compliant, but it also makes the right ventricle very sensitive to increase in afterload, whether it is hypoxemic vasoconstriction or alveolar pressure resulting in intrathoracic pressures. The right ventricle cannot withstand any increase in strain because of its weak muscle mass. As mentioned before, the right ventricle ejects the same cardiac output or the same amount of blood as the left ventricle, but the stroke work of the right ventricle is 25% of the stroke work of the left ventricle. The right ventricle is coupled with this pulmonary circulation, which is a very low resistance circuit and has a greater compliance in comparison with the systemic circulation. So it's always a relaxed working atmosphere for the right ventricle when compared to the left ventricle, which is always working under a more pressure related work atmosphere. And the ejection of the blood from the right ventricle occurs in the peristaltic phase of the cardiac cycle, or using the peristaltic method of muscle contraction, which we have already described. Now, if you look at the pressure volume loops of the right ventricle and the left ventricle, there is a little bit of difference. The amount of pressure and the decompensation that can happen with the right ventricle, the volume pressure equation is a very big and a very steep parabola for the left ventricle represented in red, whereas the right ventricle has a very shallow pressure volume loop, very similar to what happens in your lung. This pressure volume loop of the right ventricle also starts with a very flat shaped curve, and the pressure starts rising at very minimal increase in volume. So the volume sensitivity of the right ventricle also becomes a major issue. This is about preload. What about afterload? The tolerance of afterload for the right ventricle is also very different from what happens in the left ventricle. The stroke volume of the right ventricle is a very flat, is a very evanescent curve, whereas it's a very steady kind of a graph for the compared to the pressure and the stroke volume. It's a very steady graph on the left ventricle, but for at a higher pressure, the stroke volume of the right ventricle actually falls. So you can understand the importance of a afterload increase in the right ventricle based on this graph. The pulmonary vascular resistance is therefore the difference of the mean pulmonary arterial pressure minus the wedge pressure times 80 divided by the cardiac output. Now, this is the concept of ventricular interdependence. In a normal heart, the left ventricle predominates, and the interventricular septum is somewhere bulging into the right ventricular cavity, and therefore you get a half moon or a signet shaped structure of the right ventricle. This is what you can appreciate in the apical two-chamber view of the echocardiogram. But when the right ventricle fails, either because of pressure or volume overload or both, this interventricular septum becomes straight and you will find a D-shaped ventricle, and you find that the right ventricle becomes dilated, the efficiency of the left ventricle decreases, and consequently a dilated right ventricle results in a compromised end diastolic filling of the left ventricle and therefore a low cardiac output. We also need to understand the relationship between the right ventricle and the pulmonary artery. The right ventricular function should always be examined along with the pulmonary arterial function, because the right ventricle and the pulmonary arteries form a cardiopulmonary unit. Any obstruction or any abnormality in the pulmonary arteries is bound to have a repercussion on the less stronger right ventricle. And the function of this unit is characterized by two components, that is right ventricular contractility and the load on the PA, which is also called as the afterload on the right ventricle. In normally functioning right ventricle, these two components, that is the right ventricular contractility and the right ventricular afterload or the PA load, are coupled to each other and work synchronously. This RVPA coupling secures a energy efficient transfer of RV load to the arterial load. So there is a smooth transition of the cardiac output from the right side of the heart to the left side of the heart in healthy conditions when there is RVPA coupling. An uncoupling of the RVPA harmony is what results in a compromised delivery of the cardiac output to the left side and therefore a decrease in the cardiac output. So to put a comparison of the right ventricle and the left ventricle together, you can see that shape-wise, the right ventricle is crescent shaped, whereas the left ventricle is ellipsoidal. The right ventricle is made of 2 layers of fibers, whereas the left is made of 3 layers of fibers. The free wall is thinner in the right ventricle. The circulation, the right ventricle works in a low pressure, low resistance circuit, whereas the left ventricle works against a high pressure, high resistance circuit for the same stroke volume, with the ejection fraction, which is probably 5% less in the right side when compared to the left side. The ventricular pressure during diastole is between 0 to 8 millimeters of mercury, and the afterload faced by the right ventricle is also less at less than 250 dynes seconds per centimeter to the power 5. So if you look at the other aspect, which has an impact on right ventricular function, it is the heart-lung interaction. The heart and the lung cannot be working independent of each other. So if you look at the lung as 3 zones, the top portion has the highest alveolar pressure because air rises to the top and the alveoli are always more distended at the top of the lungs. So the alveolar pressure is the highest, whereas the venous and arterial pressures are little lesser. When it comes to the second zone of the lung, the arterial pressure probably predominates, followed by the alveolar pressure and then the venous pressure. So the vascular tone is intermediate in the middle zone of the lung. When you go to the bottom, where the blood gravitates to the bottom, the vessels are more open. So the alveolar pressure and the arterial and venous pressures predominate the alveolar pressure. So the maximum problems happen in these areas, where any change in the alveolar pressure can further compress this or compromise the tone and the caliber of the blood vessels. So if you look at there are 2 types of alveolar vessels in the lungs, the alveolar vessels and the juxta-alveolar vessels. The alveolar vessels are the ones which are very close to the alveoli, and which get compressed by increase in the alveolar pressure, like pulmonary, the positive end expiratory pressure. The extra alveolar vessels are the ones which are very susceptible to hypoxemic vasoconstriction. So if you look at a situation like ARDS, for example, where the PEEP is higher, so the alveolar vessels are compressed and the extra alveolar vessels are compressed because of the hypoxemia associated with ARDS. So the relationship between the alveolar vessels and the extra alveolar vessels is described here. The alveolar vessels, which are close to the alveoli, seem to have the highest vascular resistance at total lung capacity, whereas the extra alveolar vessels seem to have the highest pulmonary vascular resistance at residual volume. But the best point of optimization of vascular resistance is at functional residual capacity. So this is what we tend to optimize among patients with ARDS by optimizing the FRC so that the pulmonary vascular resistance does not become bad. So operating at this point of the PVR curve is what determines lung protective and right ventricular protective ventilatory strategies. What is the magnitude of the problem of right ventricular failure? Why are we discussing this in such great detail? The acute right ventricular failure accounts for about 2 to 9% of acute heart failures which are admitted to the hospital, with an in-hospital mortality ranging from 5 to 17%. And in an ICU, patients who develop worsening RV function have higher mortality and is associated with poor prognosis. Therefore, it is important to recognize patients with RV dysfunction very early to prevent RV failure and improve the morbidity and mortality of critically ill patients. So what are the causes of right ventricular failure and dysfunction in the ICU? In the ICU, these are patients who don't come with RV problems, but ARDS and myocardial infarction are the predominant causes of RV dysfunction in the ICU. Apart from pulmonary embolism, which can cause RV strain and RV dysfunction, you can have decompensated chronic lung disease, you can have post-cardiac surgery, both extrinsic and intrinsic factors. All these are the common causes of RV failure and RV dysfunction in the ICU. So how do you define RV failure or RV dysfunction? Acute right ventricular dysfunction is defined as an acute occurrence of RV systolic dysfunction and dilatation seen on transthoracic echocardiography, or if you are using a biomarker-based approach, a rise in the natriuretic peptide in the absence of LV or LV dysfunction or renal impairment can also be used to define RV dysfunction. Or on the electrocardiogram, if you have RV strain patterns without evidence of ischemia, you can look at RV dysfunction as your etiological cause of hemodynamic compromise. Acute RVF is defined therefore as an acute RV dysfunction plus a low cardiac output and hypoperfusion, resulting in multi-organ dysfunction or failure. So RV dysfunction is defined either by echocardiographic, biomarker-based or ECG criteria, whereas failure has to be associated with a compromised cardiac output and evidence of hypoperfusion. So this is the etiology. We won't bother too much about chronic etiology because these are the realm of pediatric cardiologists and the cardiac surgeons. We look at acute dysfunction, etiology of acute dysfunction of the right heart. Sepsis can cause right heart dysfunction with decreased RV contractility and due to RV volume overload because of overzealous fluid administration. Metabolic acidosis can cause RV pressure overload and acute dysfunction. Any hypoxemic condition can cause pressure overload. RVMI, transfusion-related acute lung injury, myocarditis, and post-cardiotomy syndromes can contribute to RV dysfunction by compromising the RV contractility and the volume overload. And inappropriate settings on mechanical ventilation can themselves increase the RV pressure and trigger RV dysfunction. So look at the various conditions. You have pericardial disease, you have pulmonary embolism, you have ARDS, you have positive pressure ventilation, hypoxia, pulmonary stenosis, and pulmonary artery hypertension, which all produce RV pressure overload. Whereas valvular regurgitations, atrial septal defects, and large volume fluid resuscitation, very common in intensive care units, can produce RV volume overload. Whereas RVMI, myocarditis, both toxic, infective, toxic, any other myocarditis can decrease the contractility. So also arrhythmogenic right ventricular dysplasia. They can all cause decreased contractility. But sepsis, intracardiac shunts, and congenital heart disease have an overlap. They can produce RV overload by an overlap of one or more of these three mechanisms. So the pathophysiology of this problem is that when there is a pressure overload on the right ventricle, there is a reduced cardiac output, which results in systemic hypotension, which causes reduced RV tissue perfusion, causing an RV free wall ischemia, which decreases the free wall contractility, which further reduces the cardiac output. And this is a self-perpetuating vicious circle. So we need to be very careful at the pressure overload causing reduced cardiac output, and we need to intervene at the beginning of this algorithm if we want to avoid initiating or triggering this vicious cycle. So if there is a pressure overload, then there is an RV decompensation, which results in a decreased RV output and a decreased LV preload because of a decreased RV distensibility and the septal shift, which we have described. The RV decompensation can also result in decreased coronary perfusion pressure. And this causes RV ischemias, arrhythmias, and inflammation, which further results in RV decompensation. In a volume overloaded condition like massive volume resuscitation, it increases the right atrial pressure, which causes systemic venous congestion, which triggers organ dysfunction, which is perpetrated also by the low cardiac output and shock caused by RV ischemia. And so this is the sequence of events which can happen in a critically ill patient with multiple factors resulting in RV dysfunction characterized by systemic venous congestion and organ dysfunction. What are the clinical features of a failing right heart? Classically, a failing right heart is characterized by raised jugular venous pressures with a prominent V wave that is produced from the tricuspid regurgitation. Usually, these patients have a low cardiac output and hypotension, causing cardiogenic shock. Because of the venous congestion, depending on the chronicity, you tend to get a tender hepatomegaly with ascites, peripheral edema, which may or may not always be present, with a precordial heave with a loud second heart sound, and an increase in the amplitude of systolic murmur during inspiration called the Carvalho sign, which may help you to distinguish a hypertensive tricuspid regurgitation from a non-hypertensive ischemic tricuspid regurgitation. But these clinical signs usually may not be appreciated in the ICU patient whose volume overloaded from other causes, who may have positive pressure ventilation and have mechanical circulatory assist devices. So what are the diagnostic tests which you will do to diagnose the patient with right heart dysfunction? An X-ray was previously used, where in a lateral view you can find an enlarged RV filling the retrosternal space, but a hypotensive hypoxemic patient with clear lung fields is probably the prototype of a patient with RV dysfunction. The electrocardiogram shows a right axis deviation with a right bundle branch block and right ventricular hypertrophy. The phenomenon of S1Q3T3 is seen in 40% of patients with RV dysfunction, and this is not exclusive to pulmonary embolism. Even patients with myocarditis and hypoxemic vasoconstriction can present with S1Q3T3 in 40% of situations. Biomarkers of late have become an important aspect of workup of patients with cardiac dysfunction. So looking at full blood counts, looking at polycythemia essentially to see whether there is hyperviscosity, renal and liver function tests, troponin for myocardial injury, lactate for perfusion, and BNP for reasons which I have described already for the diagnosis of RV dysfunction. So if you look at, we'll come back, we will just look at these numbers before, when we will come back to some of the echo parameters later. But electrocardiographically, the signs of a complete RBB or an incomplete RBB, an anteroseptal ST elevation or an anteroseptal ST depression or T-wave inversions will define a patient who is likely to have RV dysfunction. Similarly, a BNP of more than 100 or an NT-proBNP of more than 900 with absence of left ventricular dysfunction will define a patient with isolated RV dysfunction. We'll come to these parameters after we have discussed the echocardiogram. Echocardiography is probably the most important tool which every intensivist has to learn for the assessment of the right heart, where you can, by eyeballing, you can look at the right ventricular dilatation and crossly compare with the left ventricular size on the apical four-chamber view. As has been described before, we can look at the diastolic interventricular septal flattening, where the septum is shifting towards the left in a volume overloaded state. You can also look at the systolic interventricular flattening, where the interventricular septum shifts to the left during systole, which reflects a pressure overloaded state. So if you want to know whether the RV dysfunction is due to pressure or fluid or volume, you should know in which phase of the cardiac cycle the septum is shifting towards the left side. You can also identify right ventricular hypokinesis, and you can also look at the TAPC and other parameters like the fractional area change in the right ventricle, which we will discuss in the next few slides. So the static assessment, once you get the apical four-chamber view of the heart, a static assessment can be made of the sizes of chambers of the heart. You can measure the interventricular, the distance, the basal RV diameter. You can look at the mid-cavitary diameter. You can look at the basal RV diameter in the apical four-chamber view or the modified apical four-chamber view, which Guru Prasad described last week. And the normal value for the basal RV diameter is 25 to 41 millimeters. But most importantly, you need to look at the right ventricular mid-cavitary diameter, which is again visible in the apical four-chamber view, and the normal values are 19 to 35. Anything more than 38 is a dilated right heart. You can also look at the base to apex RV length, that is from the tricuspid valve up to the apex of the right ventricle in the apical four-chamber view, and this length should be less than 83 millimeters. So anything more than this would mean an enlarged right heart. Similarly, you can also look at the right ventricular outflow tract and the right ventricular outflow tract, both proximal and distal, in the parasternal long axis or the short axis views, and you can see the measurements. These are the normal values. The apical four-chamber view or the parasternal long axis view will also give you the right ventricular free wall thickness, and that should be around 1 to 5 millimeters. So this static assessment can give you a bird's eye view whether there is a primary RV problem or not. Once you identify on the static assessment that there is a right ventricular problem, you then have to assess the RV function in little bit greater detail. The most important, the well-described, well-understood parameter is the tricuspid annular plane systolic excursion, which is seen in the apical four-chamber view, which is the total excursion of the tricuspid annulus from the end of diastole to end of systole, and the normal value should be more than 16 millimeters of mercury. The fractional length shortening of the RV can also be used by using the parasternal short axis view, where the right ventricular outflow tract diameter at the end of diastole and end systole is measured. The normal value is 43%. The fractional area change in the apical four-chamber view, which is the ratio of the difference between the end diastolic area to the end systolic area over the end diastolic area, expressed as a percentage, is the fractional area change, which is surrogate of ejection fraction on the right side, and it should be more than 35%. The S prime wave velocity, which is also seen on the apical four-chamber view, which is the pulsed the time integral at lateral tricuspid annulus, needs correction for the heart rate, which is 9.5 centimeters per second, which is the lower limit, which anything lower than this, which would mean that there is a dysfunction. We'll describe it again in a short while. So this is the view. You can see that we have placed the tricuspid annulus, identified the tricuspid annulus, and put the M mode at the tricuspid annular plane. That's why it's called as the tricuspid annular plane systolic excursion. So you can see that this is where we have put the probe, and we are running the M mode, and you can see that the excursion is measured on the calipers. In the parasternal long axis view, you can actually look at the right ventricular outflow tract. You can look at the LV, you can look at the aorta, and you can look at the LA. This will give you a gross identification of whether there is any abnormality or whether the RVOT is compromising the left ventricular outflow in this picture. This is the view, the parasternal short axis view, in which you can see the various walls of the right ventricle and identify whether there is any dysfunction at the papillary muscle view level. You can actually see whether any part of the right ventricular wall is hypokinetic or asynchronous with the rest of the right ventricular wall. This is the fractional area change, where you can look at the end diastolic area and the end systolic area, put the M mode and see the two, measure the two distances, and then take the ratio for you to get fractional area change as a percentage or the fractional length shortening in the M mode. This will tell you whether there is an RV dysfunction or not. So to put everything together, the tricuspid annular plane systolic excursion measures the right ventricular longitudinal shortening and is a surrogate of systolic function using M mode of the lateral tricuspid annulus. Systolic dysfunction is likely when the TAPC is less than 16 millimeters in measurement. The right ventricular, right atrial area, which is measured at end systole just prior to the tricuspid valve opening, will also be a marker of RV strain. Values more than 18 square centimeters are considered abnormal. The right ventricular LSS, which is obtained from the right ventricular focused apical view, where you trace the endocardial border and after manual adjustment for the wall thickness, you generate the peak systolic strain. That is also a marker of RV dysfunction, and we have described the fractional area change as well. So once you identify with all these parameters, so we just go back to this slide where we have identified all the parameters. So RV systolic function is defined by a decreased function of a TAPC less than 16, RV fractional area change less than 35%, and an ejection fraction less than 45%, and the RV dilatation by the RVD-LVD ratio more than 0.9, RVA-LVA ratio 0.6, and end diastolic right ventricular diameter of more than 42. So all these parameters are echocardiographic parameters of right ventricular dysfunction. So once you have identified right ventricular dysfunction, how do you manage? As we said, the rhythm of the right ventricle is very important. So the first thing is to try to maintain a good perfusing rhythm, which is usually the sinus rhythm. At a higher heart rate, aiming to maintain a sinus rhythm, cardioversion if needed, and use either medical, pharmacological, or electrical cardioversion. You need to optimize the preload to optimize the cardiac filling, and underfilled ventricles would need small fluid boluses with a close attention to the markers of hypervolemia. If the patient is overfilled, you need to give diuretics in these patients, and sometimes you may have to ultrafilter the patient with CVVHDF to achieve your goal. You have to improve the contractility and maintain the perfusion with inodilators like dobutamine and milrinone, and use vasopressors like norepinephrine and vasopressin. Also, you need to reduce the right ventricular afterload. As I said, you cannot work under too much of strain. So you prevent hypoxia, you avoid hypercapnia, and you reduce the PEEP airway pressures, avoid atelectasis, maintain appropriate FRC, use inhaled pulmonary vasodilators or intravenous pulmonary dilators. Mechanical circulatory support like IABP, veno arterial like ECMO, or ventricular assist devices. These are all the components of management of acute right ventricular failure. So assess the RV function for early recognition of right heart failure, exclude pericardial disease, diagnose and treat the etiology specific causes like MI, pulmonary embolism, or sepsis, treat the arrhythmias, optimize the preload either with filling the patient or decongesting the patient as the situation may be, and maintain the perfusion with the help of vasodilators and vasopressors and correction of acidosis. If all else fails, you have to look at mechanical circulatory support like biventricular or right ventricular support. What are the targets when you try to treat these patients and you put them on different supports? What are your targets? You need to maintain a higher rate of at least 110, preferably in a sinus rhythm. Keep the MAP above 65, a diastolic pressure above 50. Keep the CVP between 8 to 12 millimeters of mercury, and the volumes of contractility and afterload we have already described in terms of FAC and FLS. Mechanical support for the right heart. If it is isolated right ventricular failure, you have an implantable RVAD, you have a percutaneous RVAD and ECMO, which we discussed in our ECOS workshop recently. If you have a pure pulmonary etiology, you have veno-venous ECMO. If you have LV failure causing RV failure, you have VADs, LVAD alone, and transplant and veno-arterial ECMO. These are all the mechanical supports available for the management of patients with right ventricular failure. So summarize, right ventricle is an integral part of the hemodynamic optimization. You need to know the physiology and the mechanics of right ventricle. You also need to know how to assess the right ventricle by electrocardiographic, biomarker-based, and echocardiographic tools. You need to put them all together and identify whether your patient is in a pressure overload state or in a volume overload state, and tailor your therapy accordingly. So this is about right ventricular failure, RV dysfunction, which every intensivist should know. Ghanshyam, you would like to add something?
No, Srinivas, thank you very much. I mean, for very simplifying the complex scenario of RV role in intensive care. The only point I would want to or would kind of reiterate is what you spoke about the coupling between the RV and the PA, pulmonary artery pressures, and that is extremely vital for us to remember that whenever we talk about RV failure, there is a common suggestion which keeps coming that keep loading, and give fluids. Please interpret your fluid loading or the ability of the RV to handle the preload in terms of what is happening to the pulmonary artery pressures. In situations where your pulmonary artery pressures are high, giving too much of fluid is going to be very, very bad for the RV because RVs cannot pump against a high pulmonary artery pressures. But in situations, especially with RV-MI kind of scenarios where the pulmonary artery pressures may not be very high, there, yes, fluid loading probably might help. But blindly giving fluids without actually kind of understanding the relationship between the RV and the pulmonary artery pressures can lead to further RV strain and RV failure. And that's the only point that I just wanted to kind of reiterate.
Thank you, Ghanshyam. I hope we have answered a few concerns about RV. If you have any queries or comments, please do post them on the same group on which you got the link for this webinar. We would be happy to answer them. Now, the whole purpose of hemodynamic optimization is to achieve oxygen delivery and oxygen supply to the tissues. We should but first know what is the basics of interpretation of oxygen variables and their application and clinical relevance in critical care. Like what is the AO2 gradient, what is extraction ratio, what is SVO2 oxygen cascade. So that will be, we will take a break next week for Dussehra, and we will come back on the 31st of October with this talk on oxygen, basics of oxygen delivery and oxygen variables by Dr. Mohan Sai from AIIMS Jodhpur. Have a happy festival. We'll see you again a week after this one. Have a good day and bye-bye.